Good evening, doctors. My name is Ankur Gautam, and on the behalf of FDC and Med Talks, I welcome you all to yet another episode of Diabetes Essentials with Dr. Sanjay Kalra. Today's session is on managing pain in diabetes, and today's session is brought to you by your zero calorie hydration partner, Inazal Zero. Now, to enlighten us to today's topic, I would welcome our host, Dr. Sanjay Kalra, sir, President, South Asian Federation of Endocrine Society. Now, before moving with our program, I would like to announce the last week winners of the quiz. Dr. Shantanu Kumar Bhattacharya from Kolkata, Dr. Bharat Praveen from Surat, Dr. Aran Purande from Mumbai, Dr. Lalita Bhatt from Mumbai, Dr. Nakul Bansal from Panchkula, Dr. Satish Kumar Jan from Bangalore, Dr. Sanjeev Puri from Hoshiarpur, and Dr. Harish from Maharashtra. Thank you all for joining. Now, I would hand over the session to Dr. Sanjay Kalla to enlighten us regarding our topic, managing pain in diabetes. Thank you.
Thank you, Ankur, and congratulations to all the winners of last week's quiz. We'll talk today about a symptom that is ubiquitous, that is so prevalent in our OPD. We'll talk about pain. But there is a slight difference. If you're managing a person with diabetes, the type of pain that you are managing may be different. What are the types of pains? This is something that we created, the Moan syndrome, MOAN. When a patient comes to you with moans and groans with pain, it is up to the doctor, up to the astute doctor, to figure out whether the pain is coming from a muscular origin, a bony origin, from the joints, or from the nerves. Sometimes you can't figure out. Sometimes it's all of the above put together. Sometimes it's various permutations, combinations. And you can have fluidity in moans as well. Today, the patient may come and give a history, and you feel it is a neuropathic pain. But 5 days later, the patient comes and gives a different type of history, and then you think, why did I miss this osteoarthritis? Because the patient had given a different type of history the last time. So this Moan syndrome, MOAN, tells us that we should manage pain as one single construct. And there can be different aspects of pain across a wide spectrum. Muscle, bone, that is osteo, arthro, and neuropathic origin. In persons with diabetes, pain can be stimulus dependent. For example, I touch the patient and the patient has pain. That's a stimulus. The patient moves his or her limb and then has pain. That's a stimulus. Pain can also be stimulus independent. Nothing happened. The patient did not move her limb. She did not move her joint. No one touched her. Still there is pain. It's coming from inside. So stimulus dependent pain and stimulus independent pain are important aspects of history taking. Stimulus dependent pain can also be likened in some ways to tenderness, because if you touch the patient, then there will be tenderness or pain, while stimulus independent will be non-tender. Let us look at some examples. Patient says, I develop pain at night and it keeps on worsening. I cannot go to bed. I cannot sleep. That is stimulus independent. Stimulus dependent is the moment I wear my clothes begin to hurt, my body is hurt. Or if somebody touches me or moves me, then I hurt. That is stimulus dependent. Stimulus independent pain will usually be muscular or neuropathic, more often neuropathic. Stimulus dependent pain can be neuropathic. It can be. A term is allodynia. Even when you wear night clothes, that also hurts. That is allodynia. So it can be neuropathic. But usually it will be osteopathic or arthropathic. Stimulus dependent pain will come from the bone or from the joints. And you usually will be able to figure this out on history. Temporal profile, diurnal profile, ask about different kinds of stimuli, and you should be able to clinch the diagnosis. Let's come to neuropathic pain, which is the commonest kind of pain in diabetes. Now, painful diabetic neuropathy is a very common complication of diabetes. And it's a very common form of pain, this neuropathic pain. Some people say that it affects up to 90% of diabetic patients. In my OPD, it won't be 90, but I'm quite sure it is more than 30 to 40%. In fact, in my clinic, one of the major drivers of patients coming to consult me, That is, patients' complaints, patients' concerns. One of the main drivers is pain. Why does this happen? This happens because diabetes, and especially uncontrolled diabetes, impacts the nervous system. Not only uncontrolled diabetes, but the associated dyslipidemia and inflammation, endothelial toxicity, all these have an impact on neuronal cells. They reduce neuronal cell survival, regeneration, reinnervation. They contribute to diabetic neuropathy. And when the nerves get damaged, they get altered, then we have changes in pain perception. So some people may not perceive pain at all. They have negative symptoms of diabetic neuropathy. That means they'll come and say that I cannot feel my feet anymore. They are cold all the time. But others will have positive symptoms. They will say, I feel pain at the slightest of symptoms or even stimuli or even without stimuli. There will be other people with autonomic neuropathy who will not be able to feel pain. And that is a severe complication. But in general, what we are trying to say is that diabetes and its associated complications, comorbidities, do impact the nervous system, nerve health, and therefore they change pain perception. So therefore, we must take a good history. And each and every symptom related to pain should be evaluated with extra caution. Not only the peripheral nervous system, but also the central nervous system should be evaluated. Some people may have radiculopathy. And then don't forget the other aspects of the MON syndrome, MOA, muscle osteoarthro. How do we manage pain? If we know the basic pathophysiology, etiopathology, that is hyperglycemia, dyslipidemia, vascular dysfunction, reduced blood flow, then it makes sense to treat all these. So you treat with good glucose control, with ACE inhibitor and ARB. You treat with drugs like alpha lipoic acid to reduce reactive oxygen species generation. You give nutritional supplements, nutritional optimization, so that the nerves are able to withstand all these insults. But sometimes that alone is not enough, and you would have to give treatments for pain. Now, in painful neuropathy, NSAIDs, that is the drugs that we use like ibuprofen and diclofenac, these usually do not work. Ibuprofen, diclofenac, drugs like this, piroxicam, nimesulide, these drugs will work for osteopathic or arthropathic pain. You can use them in diabetes, but try to use them for a short period of time. Do note that they may worsen renal function, so avoid them in renal failure. And also do note that they may cause a slight amount of fluid retention. So if your patient is taking diclofenac and then suddenly comes back with edema, diclofenac may be the cause of edema, fluid retention. Because NSAIDs are not very helpful, we need other drugs. So we use drugs that act upon the brain, upon the spinal cord as well, and sometimes upon the skin, upon the nerve terminals. So let us see what the treatment recommendations are before we create something pragmatic for our OPDs. The American Diabetes Association says that the first thing is to optimize glucose control. Along with that, optimize blood pressure and lipid control. If you optimize blood pressure and lipids, this will also reduce the progression, slow down the progression of diabetic neuropathy, along with glycemic care. ADA says that you should assess and treat pain. Why should you treat pain? So that you can improve quality of life. They recommend drugs like gabapentinoids, serotonin reuptake inhibitors, and tricyclic antidepressants. So we'll talk about these three. They also talk about sodium channel blockers. So 4 classes of drugs that they talk about. And they say that if you're not able to manage, then there's no harm in referring to a specialist. But the vast majority of patients you should be able to manage actually, and it won't be a great challenge if we take a stepwise approach towards managing pain in diabetes. So what's that stepwise approach? Lemon. A lemon away keeps neuropathy away, keeps pain away. So L is for lifestyle optimization. Exercise regularly. Make sure that you're physically well conditioned. If there is an issue with retinopathy or with osteoporosis, go slow on exercise, but do have a healthy lifestyle. In lemon, L is for lifestyle, E is for endocrine. We'll talk about that later. M is for metabolic and medical. We'll talk about that later as well. O is for orthotic and N is for nutritional. Let's take nutritional first because along with lifestyle, you have to optimize nutritional intake. In India, almost all of us are deficient in vitamin D. Many of us are deficient in vitamin B12. So these must be supplemented in the right doses. So healthy lifestyle, exercise, and nutrition focusing on micronutrients, vitamin D, vitamin B. Also, healthy nutrition focusing on uh, micronutrients like minerals, iron and calcium. If somebody has anemia or calcium deficiency, that should be managed. And then another aspect would be macronutrient, that is protein sufficiency. So all these must be taken care of. Once you've done lifestyle and nutrition, then you focus on medical health. So we've already talked about it. Glucose, blood pressure, lipids. Glucose, blood pressure, lipids. We follow up with endocrine optimization. Thyroid is something important that should be done. Hypocalcemia, we have mentioned in nutrition. So thyroid, hypocalcemia, and obesity. These are important aspects that we should look at. And orthotic means wearing the right footwear, the right shoes, the right socks, taking the right walking stick if required. So taking help from colleagues in physiotherapy or rehabilitative medicine if needed. And all these will not only reduce pain, they will also reduce the risk of foot ulcers and amputations. But even after having given this lemon, drugs will still be required. So see what drugs I used. So now sodium channel blockers are not used frequently in practice. Let's talk about the other three classes of drugs that ADA has mentioned. You can usually start with monotherapy. That is what I would strongly recommend. Unless the patient has already come with monotherapy inadequacy. Patient shows you slips. I went to another doctor. The other doctor gave me monotherapy. It's not worked. So if you start with monotherapy, the first line would be gabapentin or pregabalin. Standard dose to begin with, 300 gabapentin or 75 milligram pregabalin at night. But in many of my patients, especially those who are elderly, those who are frail, thin, those who do not take alcohol, I prefer lower doses, maybe 100 milligram gabapentin or 50 milligram pregabalin to begin with. Note that 300 milligram gabapentin is equipotent to 75 milligram pregabalin. So if you're starting for the first time, 100 milligram gabapentin or maybe 50 milligram pregabalin, start with it. You can up titrate at weekly or 2 weekly intervals. If it's a standard patient, you can start with 300 gabapentin or 75 milligram pregabalin at night also. The maximum dose would be 4 tablets a day, but I do not remember. Right now, I don't have any patient who's taking 1200 milligram of gabapentin or 300 milligram of pregabalin. In general, the Western literature quotes higher doses. Our patients are more sensitive. Now, if this doesn't work alone, you can add a second drug. I would recommend duloxetine, 20 milligram to begin with, and you can always up titrate to 30 milligram. Duloxetine is also used as an anti-depressant. It is an SSRI, serotonin reuptake inhibitor. But here we are using it for pain management. The added advantage is that it improves pain, and it's a safe drug to use. In some patients, you may wish to add amitriptyline, 10 milligram. The disadvantages of amitriptyline are that it can cause dizziness, increased somnolence, and also urinary retention, especially in persons with prostatic hyperplasia. The maximum dose is 75 milligram. Standard dose is 25 milligram. Do begin with only 10 and then see what is to be done. We do have FDCs, fixed dose combinations. I like a particular combination which is pregabalin 50 and amitriptyline 10 because it is a scored tablet. I can break that into half if required. Now, if these drugs don't work as monotherapy or as dual therapy, you can give any two together, or even as triple therapy, all three are being given, and you increase the dose, then you may wish to add an opioid painkiller. An opioid analgesic would be tramadol or tapentadol. These are safe to use for a short period of time. But now what is happening is in many states of the country, they are not easily available because there is a lot of paperwork involved with their prescription and dispensing. So sometimes we need alternatives. So if tramadol or tapentadol, 50 milligram BD, 50 milligram TDS is not available, you may wish to explore an alternative like Nifopam, 30 milligram TDS or 60 milligram TDS. In the OPD, I would begin with 30 BD and keep on up titrating. Sometimes you will get somnolence, so do go slow. In general OPD, practice for me is to start with 30 BD and then go up to 60 BD sometimes. One drug which I like, which is a non-opioid drug, that is flupirtine, 100 milligram TDS or 200 milligram TDS is the standard dose. I usually begin with 100 BD and then up titrate or down titrate. Sometimes in a very frail patient, I might begin half BD also, that is 100 milligram tablet, half BD. Flupirtine is available in FDC with paracetamol as well. Again, nifopam and flupirtine, they are non-opioids, but they are centrally acting analgesics. So don't give them for a long period of time, for 6, 8, 12 weeks, and try to stop. Another alternative in a disease known as restless leg syndrome. This is different from neuropathy. Restless leg syndrome is patient, the moment it becomes night, the patient begins banging his or her legs, just keeps on moving them, sometimes arms as well, and is not able to sleep. Nights are painful, but in the morning there is no somnolence. Patient is fit and fine. So pramipexole 0.125 milligram or 0.25 milligram can be given to improve the symptoms of RLS, restless leg syndrome. Sometimes RLS can be secondary to anemia or chronic kidney disease. So if your patient has symptoms like this, do rule out iron deficiency, treat it, and also kidney disease, treat that. So these are treatment recommendations, and I've sort of shared how I practice pain management in my clinic. This is what we wish to speak about today. And it's very nice seeing everyone logged in at this time on a Sunday. We need to work together to improve the quality of life, to mitigate the symptoms, the complaints, the concerns of all our fellow citizens. If we are able to do that, we will be able to gain their confidence, gain their trust. And I think at a larger level, at a mega level, we will be able to regain the trust that the medical profession is losing slowly, unfortunately. So I think we need to all work together to regain that trust. And how can we do that? By giving pragmatic, practical, prudent prescriptions to our patients, by managing pain so that the quality of life of our patients improves. Thank you.
Thank you, Sanjay sir, to speak on the topic. And your inside perspective is valuable and engaging. And we are grateful for the knowledge and experience that you shared with us. And I thank you all the doctors that who has taken your time and joined our session at a Sunday night. Uh, Thank you so much for joining.
Thank you.